Hello, welcome at SudhirEyeCoach. After a long gap, again I am in front of you. This is your love and affection which compelled me to start this video series once again. Today I am here with Phacoemulsification, in which the large area of subluxation was found. I created two side pores and filled the chamber with viscoelastics, and during the propagation of capsulorhexis you can be well aware about the weakness of capsular pull and the area of capsular dehiscence. Propagation of capsulorhexis will be difficult in the area of subluxation because the zonular traction is not there. So I found to continue the rhexis with the cystitome, so I filled the chamber once again and used Utrata forceps, because with the Utrata forceps you can give more traction to the capsule. Then again started the capsulorhexis, and always fill the chamber with viscoelastics, so that at least you can give proper tamponade to the vitreous, because the area of exposure, in initial cases, if the vitreous comes, then it is very difficult to continue the surgery. So I completed the capsulorhexis. Use of proper viscoelastics in such cases is very important. So always keep the combination of all sort of viscoelastics in your theater. Here, because I found that rhexis is smaller, so I created another nick in the area of capsule and then slightly enlarge the capsules, because if your capsular opening is less than during phacoemulsifications, we can give more traction to the capsules, and because the capsule is already weaker, so it may you can come and you can encounter capsular problems. Endocapsular ring is a saver in such cases. Always dilate properly, select the size of the ring properly, and you can use different sort of techniques for the implantation. I always use two Sinski hooks to manipulate, so always dial the leading haptic in the bag before doing the hydro procedures, because the visibility is always good. Then hold the ring with one Sinski, and then you can release it with the help of second Sinski. Do gentle hydro procedures but rigorous, means you should perform gentle, but you have to be sure that your nucleus is separate and your bag capsule is separate from the cortical matter. I use low intraocular pressure in such cases. You can see the movement of the whole capsule, because the zonules are weaker in quite big area. Your foot control is very important in such cases. Always keep control on your nerves and gently continue. Always look that your chamber is properly maintained. Hold the nucleus fragment, try to divide it so that you give less traction in the weaker area of zonules. You can see in such cases your patience is very important, and so for any good experienced surgeons, don't do any procedures in hurry. Proper visualization is very important. Keep your nerves under control and continue, and always have a look on the cornea and the posterior capsular movement. Fortunately, I completed phacoemulsification fragmentation without any problem. There was no vitreous displacement, so I continue irrigation and aspiration. And the cases where we have dialed the endocapsular ring, because of the presence of endocapsular ring, sometime it is difficult to aspirate the epinuclear plate. So you can divide it in upper and lower zone, and then easily you can aspirate the but Again, I'll say that visualization is very, very important, and all the maneuver should be very gentle and not in hurry. So almost in every case I use this BSS flush to remove the cells and fibers present on the posterior capsule, and it gives me a lot of satisfaction. Sometimes I even go in the equatorial area and then I flush the BSS, and even the cells present on the equatorial area, or the even sometimes hidden cortex, that also, you know, moves out, and the aspiration becomes easy, and it obviously reduces the chances of post-capsular formation, reduces the possibility of post-capsular formation, or it can delay it. So I dialed the single piece implant, and this is Impress implant from Hoya, which gives the decent distance and intermediate vision, because I found that centration won't be an issue. So I continued with the same implant which we selected in the pre-op period. An excellent implant, and it leaves some amount of asphericity to give defocus for the intermediate vision, and there is an addition of coma and plus and minus coma in the central 2 millimeter of the zone to give more of depth perception, and it gives a decent kind of intermediate vision, and even a slightest deviation in the centration in a longer period of time will not affect the intermediate vision. Thanks for watching.